Hello, I'm Noha Shalabi. I'm with the Neuroengineering and Pain Research Lab at the University of Connecticut. In this video, I'll be talking about neuromodulation. The International Neuromodulation Society defines neuromodulation as the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. So we know nerves work by transporting electrical signals from one end to the other. And what neuromodulation means is that by applying certain chemicals or electrical stimulation to specific areas of the nervous system, we can affect the signal transportation and thus change the nerve activity. One such signal is pain, and through neurostimulation we can alter or even interrupt the signal as it travels to the brain, and that's when it becomes therapeutic. So therapeutic neuromodulation is a pain management therapy. Through the delivery of targeted neuromodulation to the spinal cord, dorsal root ganglion, or even the brain using an implantable device called a neurostimulator, the patient's perception or experience of certain types of pain can be reduced. Currently, neuromodulation is among the most effective alternatives to prescription drug therapy for chronic pain. It is most commonly in the form of spinal cord stimulation, SCS, and peripheral nerve stimulation, PNS. They work by using neurostimulation devices that send pain-blocking microelectrical signals to the spinal cord in the case of spinal cord stimulation and peripheral nerves in the case of peripheral nerve stimulation. The degree of pain management is affected by where exactly the nerve stimulator makes contact, as well as the frequency, amplitude, and pulse width of the delivered electrical stimulation. Improvements in battery technology has been a great advantage to the field of neuromodulation, since it allowed for the development of rechargeable implantable neurostimulation devices or even non-rechargeable devices with extended battery life, making the device use and maintenance much more simple and manageable for patients. So if you take a quick look at how peripheral neuromodulation is different from spinal cord stimulation, we know that we have nerve endings on our skin and our internal organs. These nerves branch out from the nerve bundles that travel through the body to transmit the signals they receive to the dorsal root ganglion or DRG. The DRG is sort of the gateway to the spinal cord, and from the spinal cord the signals move up to the brain. So if the nerve stimulation is applied to the spinal cord or actually just outside the spinal cord, then it's classified as spinal cord stimulation. If it's applied to any other stage before the spinal cord, then it's classified as peripheral nerve stimulation. First, we'll discuss spinal cord stimulation. It consists of a very thin lead placed in the space just outside the spinal cord. The lead is attached to a small generator device that's implanted under the skin, usually in the back. This device will deliver frequent, low-voltage electrical signals to the spine that can reduce or block the severity of the pain messages sent to the brain. It's most commonly used to control chronic pain in the arms, legs, or back, usually as a result of failed surgery or nerve damage, and can help patients reduce or eliminate the use of pain medications. Implanting the device usually requires only a minor surgical procedure, and once activated, the system can be programmed and adjusted to best control the patient's level of pain. Peripheral nerve stimulation is a similar neuromodulation technique, where electrical stimulation is applied instead to the peripheral nerves. It can help relieve chronic pain that has not responded to other procedures. It's extremely useful for treating pain in areas that are not accessible to spinal cord stimulation and has been used to treat conditions such as chronic headaches, peripheral nerve injuries, facial pain, post-hernia surgery pain, low back pain, and a variety of other conditions. It can even be combined with spinal cord stimulation so they can work together and achieve better pain management. Dorsal root ganglion, or DRG, is a cluster of nerve cells in the dorsal root which emerge directly from the spinal cord. Like spinal cord stimulation, the electrode leads of neurostimulation devices can be placed close to the DRG by non-invasive or minimally invasive procedures, and it has the ability to treat pain in areas of the body that spinal cord stimulation generally can't reach. One trial even concluded that DRG stimulation gave better one-year outcomes than traditional spinal cord stimulation. It helps users manage difficult-to-treat chronic pain and can provide profound relief to those suffering from pain following hernia, knee replacement, or amputation surgeries. Conventional neuromodulation systems typically follow an open-loop paradigm, meaning the system is set up and the stimulation parameters are programmed by the clinician, then the patient can adjust the parameters and make changes to the stimulation intensity as needed. Alternatively, research and modern devices are moving more towards closed-loop control, or what's known as feedback systems. The idea is for biosignals from the body itself to be detected, measured, and used to adjust stimulation. When electrical activity travels through a nerve fiber, it causes what is known as an action potential. So, for example, we can have a spinal cord stimulation device that can detect action potential in a nerve fiber, and then it can use the properties of the action potential, the frequency or the amplitude, for example, to continue to optimize the pain relief and power consumption in a neurostimulation device. The first commercially available closed-root spinal cord stimulation system used gravity to help control intensity of neurostimulation, which could then change with the body's position, whether the patient is standing upright or lying down. It can also be used to compensate for any changes in stimulation that might be needed when the patient is coughing or straining, for example. So what are some advantages of neuromodulation? It can lessen pain without putting patients into a drug fog, and patients can avoid the side effects of pain medication. Some patients might be hesitant to go through the procedure in case it doesn't work for them, but actually the potential neuromodulation patients can test drive the modality via non-invasive or minimally invasive techniques before making a final decision. Neuromodulation devices are FDA approved and have been used in practice for 2 decades. Extensive research and clinical trials have documented its ability to decrease chronic pain and improve patients' quality of life. Studies suggest that early treatment with neuromodulation is cost-effective as it can reduce doctors' visits, hospitalizations, and ineffective or risky surgeries and misuse of opioids. And if for any reason the patient wants to opt out, the procedure is reversible. Implants can be removed if the patient chooses to stop the treatment. Neuromodulation increases activity levels and improves the quality of life of patients in pain. However, there is the problem of neuromodulation therapy failure over time. The loss of therapeutic effect is most commonly due to the body's development of tolerance. As an attempt to avoid that, future devices could utilize multiple stimulation strategies or more random patterns of stimulation to avoid the body's adaptation over time, since different stimulation patterns and signatures could evoke different cellular mechanisms of analgesia. Patients who fail to get pain relief from one form of stimulation may get better results with another. Other reasons why neuromodulation therapeutic effect might be lost include a change or progression in the disease or even a change in the patient's psychological status. In the future, neuromodulation systems need to be more flexible and programmable so the treatment can be tailored to be more compatible to specific diagnoses, conditions, and individual patients. Further research is needed for more personalized neuromodulation therapy to better understand why therapies fail over time and to better understand the physiologic foundation of neuromodulation through basic research to continually improve existing technologies and to make further discoveries. Dr. Bin Feng's Neuroengineering and Pain Research Lab at the University of Connecticut is one of the labs working on the study of chronic pain and translating scientific discoveries into next-generation neuromodulatory strategies and devices that can target peripheral neurons as non-drug alternatives for managing chronic pain. To give you an idea of one of the projects the lab is currently working on is the use of DRG stimulation to relieve visceral pain in patients with irritable bowel syndrome. Irritable bowel syndrome affects about 6 to 18% of people worldwide. The aim of this work is to guide the design of next-generation DRG stimulation devices for effective management of chronic visceral pain while minimizing off-target side effects. Another example of the work the lab is doing is the development of a technique to obtain efficient recordings from single nerve units to improve our understanding and control of peripheral neuromodulation. The motivation behind this work is the fact that therapeutic use of peripheral neuromodulation is limited to only a fraction of chronic pain patients. So research is needed to understand why that is and to work towards helping people benefit from neuromodulation. Thank you very much for listening, and I hope this video was useful to you.